at the rank of firefighter and a paramedic here with the fire department. So I spend a lot of time on the ambulance, which is what I'm on today. I got to do a little bit of disclosure. I am on duty. So there is a possibility that I'll get yanked away, but we'll just keep rolling until that happens. So a little bit of the background on me. I know that you guys, as I was approached about this, doing a bit of a triage review as it relates to the CERT triage system, that I'm under the understanding, Paul, everybody who's here has had the initial training on. Is that correct? You guys have all been introduced to the CERT triage. It's not totally unfamiliar to you. Is that correct? Okay. And so tonight's, I was asked to do a little bit of a review on that. And so I have some information that we'll cover regarding the CERT triage system, and then just some, I guess, tidbits of information for you guys to try and, I guess, help facilitate where you guys see your role fitting in on any kind of a mass casualty incident, which is where obviously that this system would be used. And then augmenting kind of the systems that we're doing at the fire department to help facilitate, streamlining things. So when I thought about this, in our world, in the recent past, in the past few years, a lot of this has been changed and kind of been an updating thing for us. And particularly as it's been a response to mass shootings has been the big thing. And so, but I think this would be more applicable in your scenario if we're talking about it like a large scale natural disaster type event. And I'm thinking something along the lines of an earthquake where our on-duty personnel and even off-duty personnel, provided they can make it into work, depending on the scope of damage, would be quickly overwhelmed. So, you guys doing some sort of roving patrols through neighborhoods, searching for people, and then you're confronted with some sort of secondary incident, like a building collapse or something like that, where now you guys are kind of the ones handling that triage component. So without further ado on that, we'll talk a little bit more here about that in a second, but I'd like to dive in with you guys. I'll be following down, we'll kind of reference your, what we'll call the flow sheet of the CERT triage system for you as you, initially make access to victims and then try to sort out by priority. And I would say that fundamentally, and this is an attitude I certainly carry about an MCI or mass casualty incident, which we define as 5 or more people anticipated needing transport from one event, basically. So if we're guesstimating that at least 5 people are going to need transport to the hospital, we will declare an MCI. Now, a lot of times those are ones that are isolated instances that you guys might never get activated for, but just a little bit of an idea of when we try to, we effectively kind of pull that trigger on mobilizing this system. So when you guys first make access, the thing I want to say is that what we keep in mind is that we want to try and maximize, we want to do the most good for the most people, if that makes sense. I will tell you that this type of a scenario is going to be chaotic. There's no other way to explain that, okay? There's going to be a lot going on and things can quickly feel overwhelming. But if we stick to these basic principles and we always in the back of our mind are thinking, how can we maximize doing the most good for the most people? Then it helps us kind of stay in our zone and work within our capabilities. Triage obviously meaning to sort. It's a French term, but so what we're trying to do is sort people based on immediate need and immediate life threats. And when we talk about immediate life threats, we're talking about the 3 big killers of people in a mass casualty incident, which would be their airway, their bleeding, and then management of shock. And shock can be tricky because especially in a scenario like this, you're going to have citizens that are overwhelmed in a state of what I will call like a shell shock, where they may not be in a medical shock per se, because shock is strictly defined as something that impedes our ability to distribute blood. And it can be a little bit trickier, but we have some tools for that as well to determine whether or not someone's in a state of shock. So airway is the first thing, and that's the first thing that we look at when we're talking about start triage. So as we start into the triage system, we've got the 4 categories that you're probably already familiar with, but green being what we'll call the minor injuries, or so the walking wounded per se, or people who are uninjured. And so when we approach a group, however many it may be of victims, the easiest thing to do to sort the greens out would be to say, if you can stand and walk here to some, it might be 50 feet off to the side. It might be to a CERT member who kind of would be that designated spot for them to go to. So in that moment, anybody who can get up and walk to that person can do so. And then those patients are green patients, the ones that can ambulate and move. And then from there, the patients that we need to sort out into the other 3 categories would be something that we do as a direct assessment, individual to individual. As we approach the person, and you can see here, which this arranges it a little bit differently, what you see on the screen, but it's the same concept as what's on that flow sheet that I saw that you guys had in that print off version. When you approach a victim, first we need to assess whether or not they're breathing. And if you think back to your CPR instruction as well, the look, listen, and feel for breathing. And give it a few seconds to see if they have respirations. If they are not breathing, then we will do a quick reposition of their airway. And from looking at your guys' slides from before, it sounds to me as if you were trained on the head tilt chin lift, if that sounds familiar to you, to reposition and open an airway. Yeah. So one hand on the forehead to press the head back, and then fingers underneath the jaw to thrust the jaw forward. Once you reopen that airway, if they are breathing, at that point, they become a red patient. If you've had to open their airway to get breathing to be spontaneous on their part, they become a red patient. If they are still not breathing after that one attempt at reopening the airway, then that person is labeled as a black or expectant patient, and then we move on. And when we're talking about saving time, I want you to think, we do give it that one attempt, and it's going to be difficult if someone's not breathing to leave their side and go to the next person. But again, if we're thinking back through doing the most good for the most people, we need to move on and rapidly assess who can be saved as quickly as possible. So again, reopen the airway once if they're still not breathing. Label them as an expectant or potentially already deceased patient, and we move on to the next. In a pediatric scenario, it's a little bit different if you are trained at doing it, and also if you're comfortable doing it, because some people, they may not be comfortable doing mouth to mouth, or if they don't have the right equipment or something like that. In a pediatric patient, we can give them 2 breaths if they're not breathing after we've reopened that airway, and to see if that can initiate breathing on their own and before we move on. And typically we define a pediatric as roughly, it can be tough to define, but 6 years and older is typically where we'll cut that line if we're talking as it relates to the START triage system. And obviously you would probably have an idea of what kind of patient base you're dealing with, depending on the disaster. If it's a bus crash of a school bus, you're likely to deal with more pediatrics, for example, than adults. So once we get past the breathing component, we've opened the airway. We've either labeled them red or black. Typically, if we've had to open the airway and we either get breathing or we don't, then we move on to assessing their breathing rate. So this is where you do the 30, I believe the 30 and 2 can do, right? So we are going to count their respirations, and anybody who's breathing faster than 30 times a minute becomes a red patient. And the easiest way to do that would be to just count for 15 seconds and multiply by 4. Just count a rate at 15, and then at 15 seconds, multiply by 4, and then there's your 30 per minute or less. in a situation, this can get tricky too, because people might be mentally overwhelmed and hyperventilating. It may not necessarily be an airway problem, but they are mentally kind of reach their max. But again, just stick to the 30. If it's less than that, then we move down the line. If it's over that, we label them red and we move on. Once we've counted their respirations, this is where we get to the 2 category. And there's 2 ways of assessing their circulatory system. We can assess for a pulse, which in this case, we try to do the radial pulse down in the wrist, because that's our best indicator of adequate circulation through the periphery, the distal parts of the body. So assess for a pulse there, or you can assess what we call their capillary refill. And on an adult, the easiest way to do this would be to take a finger and pinch, and then assess to see how long it takes for color to return to the skin. And our number there, our big defining marker there is 2 seconds. So if it takes longer than 2 seconds, then they're a red patient, because we are concerned about circulatory compromise, which in turn leads to shock. If it's less than 2 seconds, and or if you have a good strong radial pulse, then we continue down the flow chart. Then we get to their ability to mentate, to be focused. So give them some basic commands and see if they're able to follow that, or they're able to track with you on what you're trying to talk to them about. And just use your judgment. You know, it's not rocket science. It's just determining whether or not somebody's, you know, engaged in the moment with you. If they are able to follow those commands, they are labeled a yellow patient, because again, if they had been a green patient, they would have been able to answer the command and get up to walk to a designated area previously. So those are our yellow patients. If they're unable to follow commands and they're clearly confused, then they are labeled red. And so to kind of correlate it with what we're doing, this is the same system that we use at the fire department. It's the same system that we use countywide with the other EMS agencies. And it's the most commonly used system in the United States for rapid triage. So what you guys are being asked to assess is not altogether different than what we're doing either.
Tim, I actually did get a question.
Yes.
Going back to the pediatric step. Does Kat asked if you would recommend a mouth sweep before the 2 breaths for pediatric?
Yeah, you know, I again, the big thing is we're minimizing time. So that, you know, they talk about the really from person to person, we're trying to stick to 30 to 60 seconds, right, for this assessment. So yeah, I don't see a problem with a mouth sweep. There's, you know, sometimes a mouth sweep can be a little bit tricky because it depends on what is blocking their airway. If we're talking about fluid or blood, that's one thing. If they have facial trauma, for example, and we're talking about dislodged teeth, bone fragments, whatever it may be, an airway sweep can sometimes make that airway compromise worse by further clogging the trachea. So it's same concept as if you can't readily, like, and I'll correlate this with, you know, when we talk about CPR on a choking victim, right? If you can't easily see what's obstructing their airway, then you don't necessarily want to push it further down. So I would, if I was thinking about that on a pediatric, and, you know, if I'm looking at them and they look like they could benefit from that, and they, you know, clearly aren't already deceased from some other obvious factor, you know, then I would visualize the airway first before I just started blindly sweeping with my finger. If there's something that looks like it's clearly obstructing it and I can access it easily, then certainly. Does that answer the question?
Yes, thank you.
Okay, yeah. So yeah, again, just to kind of, well, like I was saying, it's the system that we're using as well. The only difference for us is that we do have some things that we do as a very rapid form of treatment in that triage phase that certainly you guys wouldn't be asked to do. But aside from that, there is no difference as far as what this system uses to determine, you know, green, yellow, red, black. So it's the same parameters for us as well. So I know that on your flow sheet as well, it talks a little bit about secondary triage. And again, that's going to be a step that's completed once you've identified and sorted all of your victims initially in that rapid triage phase. And sometimes the secondary triage actually occurs in the treatment area. So depending on if there's other environmental hazards where we need to extricate victims rapidly, things like chemicals and gas and stuff like that, where the treatment area needs to be somewhere that's safer. Some of this secondary stuff happens there. But I can certainly see a situation where, depending on the level of our CERT response, some of you may be in helping facilitate that treatment area, whether it's helping with supplies with our medical personnel, or helping just tend to victims, whether it's, within your training or just to be helping facilitate as a, support. And that's when we get into what we talk about with the head to toe survey. And Paul, certainly if I'm digressing beyond where you wanted to keep tonight's things, just let me know.
No, that's great. I was just trying to come up with a slide for you. I don't really have one, except I do have
I had only seen it on that at the end of that flow sheet that I'd received in that PDF.
Right.
And so
I do have the patient exam card, which is sort of a part of triage and also a little bit more of a second step. Like
certainly, yeah. And this is actually a good example here. It's something that you wouldn't really see this kind of a card in that rapid triage phase. You'd see this more in that treatment area where you're now identifying their vital signs based on numbers, right? Like initially when you're counting respiratory rate, it's over 30. You don't really care about the actual number itself. You just know that it's either above or below that benchmark. And so what we're looking for in our head to toe survey is we need to expose injuries, cut clothing away, and identify what might be creating, their medical needs at that time. And I know that you guys are have you guys reviewed I see that you're given the standard vital signs for adults and pediatrics and whatnot, as far as pulse ranges and things like that. Is that something that is familiar to you, or you recall? I wonder if this might also have been something Chris added at the end, but it's not part of the start thing. So I can leave that be for now.
Okay.
But ultimately what I want you guys to take away is to keep this simple. And like I said, hopefully we don't encounter a situation like this, but when you're there and faced with the chaos of the scene, and I told you inevitably it will be for us as well. You just manage the chaos by sticking to what you know, keeping it simple, and keeping the attitude that you're going to do the most good for the most people. Does anybody have questions on the flow sheet? I went through it somewhat quickly.
My question is, have you ever experienced someone who's actually in shock, who is at least initially or temporarily able to respond to the walk over here command? Or perhaps someone who is approaching shock and still able to perform?
Yeah, that's a good question. So the first part of that, I would say no. Once someone's progressed to that phase of the medical shock, where we're talking about an issue of their circulation and ability to deliver blood to their vital organs. Once they progress that phase, it gets pretty obvious. They are either extremely confused, they may not even be fully conscious or conscious at all, and their look, and that might be like, well, what does that mean? Like as far as their skin is just terribly pale, and then where we see it on my end is it manifests in at really abnormal vital signs, very severe low blood pressure, very rapid pulse rate. So no, I would say that it would be incredibly unlikely for someone who is either in medical shock or on that precipice of it to be able to follow the command to get up and walk without difficulty to you. Yeah, that would be, and I've never personally, once someone's in shock, it's they have a difficult time regulating their own needs without intervention, if that makes sense.
Sure. Thank you.
Yeah.
Okay, Dana, did you have a follow-up question? You had bleeding.
Well, I'm getting confused. I think it's between the Knowles training and the CERT training is where do we assess the bleeding?
Okay. So I know that, and it's I think it's in that other slideshow as well. There it talks about the different types of bleeding, where we're talking arterial, venous, or capillary bleeding. Arterial bleeding is going to be quite obvious.
Yeah.
You know, it's the spurting type, right? And so patients who have that don't have a lot of time. So when we're talking about, and I'm assuming you're differentiating between when do we intervene with bleeding control?
Where does it come into the triage? And I'm thinking if it's arterial, it's the first thing, because obviously if they're spurting blood all over, we need to do that first before we do the airway. Yeah.
So it can get somewhat convoluted, right? Pretty quickly. So arterial bleeding is also going to be, and it may not even be something you see, especially if they're clothed, right? So if you're assessing for pulse or capillary refill with arterial bleeding, you're not going to hit those benchmarks for the 2 seconds or the distal pulse, right? So that patient would be labeled red, and we would move to the next patient because so let me think on that real quick, because I'm not terribly familiar with the other training that you guys did for bleeding control.
It doesn't matter.
Is that in an isolated patient?
I just wanted to make sure, because we know it's the ABCs and where does the bleeding fit in.
So the difficult thing is that in this case, you don't, what I don't want to happen is to tell you, you need to manage that person's bleeding right there at the expense of assessing the needs of X amount of other people.
Okay.
Right. So in that case, that person would be labeled red. If it's something that you can stop or at least try to mitigate with, I'm assuming that, because I was looking at your guys' slides from before, where we talked about pressure points, like direct pressure to stop bleeding. And it's also dependent on what you carry in your kits. As far as, so just as a case in point, and I did bring one in, when I'm doing rapid start triage on an MCI, I have a belt kit here, but we have things that clotting mechanisms that we use and tourniquets that you guys don't typically have access to. So I would say if you can stop the bleeding with one quick attempt, and again, just keep that 30 to 60 seconds barometer in your mind, right? Yeah. If you can mitigate that bleeding significantly with one attempt, then, identify that this patient needs to be extricated. If there's fire department personnel on scene or you have multiple CERT people, but then don't delay getting to the other patients beyond the time you devote to that first one.
Yeah, Tim, that's what I see as the important takeaway for me, is that if I'm having to do a direct pressure and stand there or put on a tourniquet or something, then I'm not able to help the other people.
And I don't want, and this is where it gets really hard, because it's going to pull at your, it's going to pull at the strings to move on. And so, with that answer being as vague as it was, I'll talk to Chris and just see what the expectations are for you guys within your role and see if I can get you a better answer.
Thank you.
Does that work? Okay. I apologize for the,
you're doing great. And this has been it's a wonderful review. Thank you.
Okay. And like I said, I don't want things to start getting people tunneled down rabbit trails at the expense of and that's why it's kind of one of those buzzword type of things to say, about doing the most good for the most people. But that's what it comes down to, because, we're going to have limited resources. There's only so much we can do individually. So we try to maximize what we can provide as benefit to the public. And that's the attitude we carry at the fire department as well. So
yeah,
I'll try to get you a little better answer on, just when that trigger point is, right, to move on.
Yeah, thank you.
Steve's got his hand up.
Yeah.
Yeah, I was sort of thinking that might be a perfect place. You have all these green people who are ambulatory, and just grab one of them and have them, hey, hold the pressure point here, and then you can move on.
And that's actually a great point, Steve. And you can, it certainly is within your capability to be like, anybody willing and capable to help, please do so. And, it's, you guys are familiar with, how to apply direct pressure. And I imagine you guys have also reviewed, pressure points and things like that, like, the brachial artery, where that's at, femoral artery, that kind of stuff, popliteal artery in the leg. Say, hey, here, hold this spot. They don't have to know anything about medical training. And if they're willing to do that, then yeah, utilize the people that are capable and willing to help. So that's a good point.
All right. Okay.
Any other questions? Kind of a down and dirty. I apologize. It's kind of a rapid review there. But really, I can't emphasize it enough to keep it simple, because the scene and the situation are going to try to overwhelm quickly. Mm-hmm. So just keep to what you're trained to do, and do that to the best of your ability, and that's all that can be asked.
All right.
So
thank you very much, Tim. That was terrific.
Any other questions? And this is something that's, it's this triage system has been something that has, over the last, I'd say, decade, maybe 15 years, they've really tried to streamline things on a national level. But we do a lot of review on past incidents across the nation. And each time it comes up, the big thing is that, the responders talk about how chaotic it is, and things will want to break down. So just stick to what you know. Okay. And just as long as you're operating with good intent, then that's what we're there for.
Cool.
So.